Assalamu alaikum. Today, let's explore COPD, this essential topic, and break it down step by step. Okay, before talking in, reading this, first I would like to talk about what is COPD, chronic obstructive pulmonary disease. It encompasses several progressive lung disorder characterized by persistent airflow limitation and chronic inflammation, where in the lower respiratory tract. So, COPD actually encompasses several progressive disease characterized by persistent airflow limitation and chronic inflammation in the lower respiratory tract. Okay, if we go into the pathophysiology, if we break it down, a range of permanent change in the lower respiratory tract seen in the COPD, like chronic bronchitis and emphysema. We know that chronic bronchitis and emphysema. Okay, what are its precipitants if we read this? It may be infectious, it may be non-infectious. In infectious, there may be respiratory viruses like rhinovirus, and commensal bacteria like non-typable Haemophilus influenza. These two, rhino and non-typable Haemophilus influenza. This is the infectious cause, and the non-infectious, there may be sterile inflammation, underlying disease may be present, pulmonary embolism, inhaled irritant inhaled irritant inhaled irritant. Actually, cigarette smoking is one of the dominant risk factor, but there are some other environmental, genetic, and developmental causes are responsible for COPD to happen. Okay, what happens in here? If we look at the pathophysiology and the presentation, there is bronchial inflammation. There is bronchial inflammation, systemic response, fever, leukocytosis usually systemic response, fever, leukocytosis usually absent. So there is, we know in the pathophysiology there is air trapping and there is hyperinflation. There is air tapping, there is hyperinflation, and there may be impaired gas exchange. So if we break it down, the pathophysiology, there may be air trapping. Why there is air trapping? There is air trapping due to proteolysis of the air trapping due to proteolysis of the lung elastin, due to proteolysis of the elastin, mm, and loss of tethering leads to easy collapsibility of the small airway during expiration. And there may be hyperinflation. Hyperinflation, it is happens due to loss of elastin, which leads to increased lung compliance, very high yield. This increased lung compliance happens due to loss of elastin and decreased lung elastance, which allows the chest wall to expand the lungs outward at a higher resting volume and increase functional residual capacity, increase FRC. Okay, COPD is thought, if we tell COPD in a single word, like difficulty getting the next breath in due to difficulty getting the last breath out. So it's a simple word, difficulty getting the next breath in, as there is a difficulty in getting the last breath out. Okay. In cardinal symptom, these three things you need to must remember. Cardinal symptom: increased dyspnea, increased sputum volume, increased sputum purulence, increase dyspnea, increase volume, increase sputum purulence. Okay, and there is increased work of breathing, which leads to hyperinflation. I have said that hyperinflation due to loss of elastin, increased work of breathing, loss of elastin, and impaired gas exchange, hypoxemia, decreased VQ, and hypercapnia, hypoxemia, and hypercapnia. And in management, the simple management you need to remember: maximize expiratory flow. Maximize expiratory flow, give inhale bronchodilator, reduce airway inflammation, give systemic glucocorticoid. Maximize the airway flow, inhale bronchodilator, reduce airway inflammation, systemic glucocorticoid. Treat the underlying trigger, antibiotic or antiviral, influenza, COVID-19. Maintain adequate oxygenation. Our SpO2 target is 88 to 92%, and maintain adequate ventilation, ANI, non-invasive ventilation and invasive mechanical ventilation. Antibiotics generally indicated where if there is increased sputum purulence plus one of the cardinal symptoms like increased dyspnea or increased sputum volume, and patients require hospitalization. Antibiotics indicated if increase this and increase, and patients require hospitalization. Okay, COPD. Jugular vein distension may be observed on physical examination in acute COPD. Very high yield. Acute COPD exacerbation, you can see the jugular venous distension, and during expiration due to increased intrathoracic pressure. Physical examination may show wheezing, tachypnea, prolonged expiration, and use of accessory respiratory muscle. Mechanism of trigger, like in COPD, if somebody has a respiratory tract infection, then COPD can exaggerate. So, when should intubation be considered in a patient with COPD or asthma exacerbation? If profound acidemia, very, very, very high, if there is profound acidemia, pH is less than 7.1, poor mental status, somnolence, lack of cooperation, if there is hemodynamic instability. These are the reasons, like profound acidemia, poor mental status, and hemodynamic instability. Otherwise, begin and initiation of non-invasive positive pressure ventilation in patient with respiratory failure, and endotracheal intubation with mechanical ventilation is recommended for after failing of trial of the non-invasive positive pressure ventilation. Okay, Global Initiative for CO chronic obstructive lung disease. The gold recommended antibiotic therapy for patients who have COPD exacerbation with any of any with any two of the following features, like increasing sputum purulence, increased sputum volume, and increased dyspnea, like three cardinal feature: increased sputum purulence, increased sputum volume, and increased dyspnea. Antibiotics are recommended those requiring mechanical ventilation, non-invasive versus invasive. Okay, what is the most likely diagnosis in a patient with extensive smoking history? Extensive smoking history, coronary artery disease, hypertension, who present with 1 week history of exertional dyspnea, 1 week history of exertional dyspnea, bilateral crackles, and occasional wheezes. ABG shows respiratory alkalosis. This is congestive heart failure. Exertional dyspnea, bilateral lung, and occasional wheezes, and ABG show respiratory alkalosis. It is congestive heart failure. Congestive heart failure will have respiratory alkalosis, but COPD will have respiratory acidosis. Most important, congestive heart failure, respiratory alkalosis, pulmonary edema, reduced ventilation causing tachypnea and loss of carbon dioxide. Pulmonary edema reduces ventilation causing tachypnea and loss of the carbon dioxide. In COPD, there is respiratory acidosis. widespread wheezing. There is respiratory acidosis, widespread wheezing. Pulmonary embolism is acute onset. Pulmonary embolism in acute onset. So congestive CHF, think about respiratory alkalosis. But in COPD, think about respiratory acidosis. So if you do an ABG, we can differentiate the respiratory acidosis from respiratory alkalosis by doing an ABG. And there is some, like, don't jump into the diagnosis, extensive smoking history, so go for the COPD. No, that's not the way of diagnosis. Looks like COPD, but it is congestive heart failure. So high carbon dioxide respiratory acidosis help to differentiate from CHF exacerbation, which causes low CO2 and respiratory alkalosis. So low CO2 and respiratory alkalosis. Think about congestive heart failure. But in COPD, there is high CO2, more CO2. Patient is unable to breathe out the CO2. High CO2, respiratory acidosis. Think about COPD. Okay, if what chest X-ray finding may be found in a patient with COPD, hyperinflation with flattening of the diaphragm, more than eight more than 8 rib count, the hyperinflation, more than 8 rib counts. If there is more than 8 rib count, think about more than 8 rib count, think about hyperinflation. What physical examination does it produce? What physical examination does it produce? What physical examination does it produce? Distant heart sound. Listen at Zephyr process. Distant heart sound. Listen at Zephyr process. Okay, if we look at the rib count, if we look at the rib count, look at here. This is the magnifier. If we look at the rib count, if it is more than 8 rib count, think about hyperinflation. Think about hyperinflation. Okay. Okay. Okay, now patients with acute exacerbation of the COPD are at risk for symptomatic hypercapnia, and should be promptly investigated for with AVG analysis. So high CO2 hypercapnia should be promptly doing AVG. Clinical manifestation predominantly neurologic. Clinical investigation Clinical manifestation predominantly neurologic and include headache, hypersolmonance with mild to moderate hypercapnia, high levels of hypercapnia. PaCO2 is more than 75 to 80 millimeter of mercury and can cause confusion, lethargy, and eventually coma. Carbon dioxide necrosis, eventually coma. Carbon dioxide narcosis, and with our seizures. Severe COPD accompanied by pulmonary cachexia, which is characterized by loss of lean muscle mass due to energy imbalance and systemic inflammation due to energy imbalance and systemic inflammation. Okay, before jumping into this, look at here. What is the two intervention to improve mortality? Smoking cessation, long-term L-thought, long-term oxygen therapy. If PO2 less than 55 and oxygen saturation is less than 88. If PO2 is less than 55 and oxygen saturation is less than 88. If oxygen saturation is fine, then mm, oxygen is not indicated. Survival benefit of home oxygen therapy are significant when it is used more than 15 hours a day. MTB says pneumococcal and influenza vaccine decrease mortality. Okay, and the you all says just decrease the rate of COPD exacerbation. Okay, these two things you need to must remember: resting arterial oxygen PaO2 less than 55, or pulse oxygen saturation SaO2 is less than 88 millimeter of on room air. If PaO2 is less than 55 and SaO2 like pulse oxygen saturation is less than 88 millimeter on room air, give L thought. If PaO2 is less than 59 and SO2 is less or equal to 89, in patients with core pulmonary evidence of right heart failure and hematocrit more than 55, give L thought. The primary long-term intervention for COPD is daily long-acting anticholinergic inhaler. Ipratropium, tiotropium may be combined with SABA or greater symptom relief. Inhaled steroid and LABA can be used for patients with more severe COPD. Oral versus IV steroid for acute exacerbation. Okay, look at here. Group A. In Group A, we just give bronchodilator. SAMA is used. Short-acting muscarinic antagonist SAMA. And Group B, mm, LABA LAMA. Group B, LABA LAMA. And in Group E, LABA LAMA ICS. Long-acting beta 2 agonist, long-acting muscarinic antagonist, and inhaled corticosteroid. And in Group A and B, none requiring hospitalization and less than two outpatient systemic corticosteroid, and for Group E, more than one requiring hospitalization or two or more than two outpatient systemic corticosteroid. Inhaled corticosteroid recommended if plasma eosinophilia is more than 300 per millimeter of Q, is present but avoided in patient with recurrent anemia in is present. Okay, okay, that's all about COPD. Hope you enjoyed.